going to start today with Luke Turnier, who is a pediatric psychologist at the University of Michigan in the rheumatology clinic. He works closely with his wife, Dr. Jessica Turnier, and with our kids in juvenile myositis. Luke, would you like to start?
Absolutely. Can everyone see my presentation?
We can see it.
All right, great. Well, thank you so much. Good afternoon, everybody, and thank you, for having me. Thank you to CureJam for hosting these panels, to provide an opportunity for families and all of us to get together to talk about these really important issues. I really appreciate that. And so today I'm going to be talking about anxiety and mood-related challenges among children diagnosed with JDM. I want to say that within the field of psychology first, and mental health, there's a lot that's known about the assessment and treatment of children with chronic illness, but also there's a lot more work to do. And as of now, JDM is an area that's in need of a lot more mental health research, and I'm really committed and happy to be a part of that process. So today, my primary goal is to provide a very brief overview of anxiety and depression, and also hopefully provide a few straightforward and manageable suggestions or things to think about when we're noticing anxious behavior or low mood in our kids. I had some initial slides to kind of set the stage for this presentation, but I found that it ran a little bit long, so I'm just going to jump straight into my personal and kind of anecdotal experience in the JDM clinic here at the University of Michigan. And so with these slides, one thing with these data, it's important to remember is that these percentages are not generalizable data. Okay, this data is not saying that, X% of children are likely to have anxiety or express anxiety or depressive symptoms if they're diagnosed with JDM. This is really just a snapshot of the clinic and kind of the frequency at which children reporting these concerns. There's a lot of other possible contributing factors to parents reporting these concerns, in addition to just the diagnosis of a chronic illness, disease activity, the age of onset, length of illness, other comorbid conditions. So really, we're just looking at really a set of 41 initial first visit contacts with psychology and what are the concerns regarding mental health as they're coming in the door. And what you can see here is that 32% of caregivers endorsed mild or moderate anxiety concerns at their first visit with me, and 26% of children over the age of 8 endorsed mild or moderate anxiety concerns at first visit as well. And I measured this using a measure that's called the PROMIS 25. It's a norm-based measure that measures 6 specific areas. It assesses mobility, anxiety, depression, sleep, pain interference, and social relationships. So for this presentation, I'm focusing primarily just on anxiety and mood. So what is anxiety? I would venture to guess that most of us here, if not all of us, have experienced some anxiety at some point in our life. There are psychological kind of factors associated with anxiety in addition to physical symptoms of anxiety. Psychological factors include things like feeling tense, feeling worried, fearful, crying spells, rumination, kind of the difficulty to kind of let negative thoughts go, or worrying all the time and not feeling like we can change our minds or get it to slow down. Some physical symptoms related to anxiety are a rapid heart rate, especially in acute anxiety, quick, shallow breathing, nausea, insomnia. Primarily with anxiety, this can often look like difficulty falling asleep, low appetite, sweating, or tremors. One thing to think about in children with a chronic disease is that sometimes it can be difficult to differentiate anxiety symptoms versus physiological symptoms associated with illness or even side effects with medication. But as we can become more familiar with medication use and even kind of the symptoms of the chronic illness, parents and we're able to kind of differentiate those things a little bit better. So before we talk about ways to kind of address issues of anxiety and the areas that I see anxiety most frequently in clinic, it's important to understand the functions of anxiety. And by that, I mean, what makes anxiety stick around? Why is it that despite many conversations about needing not worry or try to calm down, everything's going to be fine, anxiety seems to be persistent nonetheless? And the reason is because symptoms of anxiety are reinforced through 2 primary processes, and those processes are escape and avoidance. And put simply, pretty much escape is, in the short term, when presented with a stimulus that causes anxiety. For this example, let's say it's an infusion or maybe a needle poke. Our anxiety kind of shoots through the roof pretty quickly. And so our first impulse and an effective impulse for the anxiety is to kind of escape the stimulus, right? To move away. Assuming that behavior was successful, anxiety would come down pretty quickly. Now, it's a pretty effective strategy, right? In terms of dealing with anxiety term. But unfortunately, it also reinforces the very anxiety that we want to reduce over the long term, because we kind of learn through what happens in our own physiology and our own body that our anxiety is quickly reduced if we just move away from the thing that's causing us to worry. Now, secondary to that, we have avoidance strategies, and it's kind of once removed from escape. Sometimes we just know that if we don't put ourselves into a position to be anxious, then we don't have to feel it, right? And so sometimes kids learn that if they can delay kind of a procedure, or maybe they're waking up late or hard to get in the car, these are avoidance strategies that for a child can be very reinforcing, because for children, especially younger children, even a minor delay in a non-desired activity can reinforce a behavior, right? And some of that has to do with cognitive development. Younger kids especially don't perceive time the same way adults do. For kids are very, very present. They're very here and now. And so for kids, if it's now or it's not now, right? And so sometimes we see these escalations of avoidance behaviors because even a small delay can kind of reinforce that over time. So in terms of more specifically in ways or kind of symptoms of anxiety or presentations of anxiety that I see in the JDM clinic most commonly, a big one that I alluded to already is anxiety related to medical procedures or administration of medication. Most often, I would say it's like weekly methotrexate injections or oftentimes monthly infusions can cause a lot of procedural related anxiety in kids. And so I do a lot of work with kind of needle phobia and those kinds of things. Another big one is more related to generalized anxiety, or I would call it more specifically in this case, anticipatory anxiety, just regarding the implications of illness in general, and also just worries about frequent doctor's visits and that kind of thing. So just worries about what's coming up next. And I'll talk about kind of what that looks like for parents in just a minute. And also another big area of concern has to do with just kind of social relationships or school concerns. A lot of our kids have to wear long sleeves or make sure they're putting on sunscreen, even if long sleeves, even though it's really, really hot outside, so their skin doesn't react. How do they talk to peers about illness? They can be worried about those kinds of things. And so with this, what does this kind of look like? And talking with parents in terms of anticipatory anxiety specifically, parents have reported to me that their children will often ask frequent questions about upcoming medical visits or procedures. When are we going to go? How long are we going to be there? Am I going to be able to go back to school? Is so-and-so provider there today? Do I have to have a shot today? And despite kind of answering these questions, they seem to kind of keep coming back. And so another common behavior is kind of the delays that I alluded to earlier. So really just engaging in any behavior that's not the expected or desired behavior in order to kind of put off the things that we don't want to do. So what do we do about these kinds of things when we're parents, when we're at home, and we kind of see these kinds of anxious behaviors? So there are evidence-based strategies to adjust kind of generalized or anticipatory anxiety. And oftentimes, for a lot of kids, not just kids that have a diagnosis of JDM, we get this kind of behavior that's these frequent questions, right? And despite our best efforts and natural, right, a natural response when our kids come to us for help, our parents' instinct is to help, right? To help them calm down. Well, don't worry, I'll be there the whole time. Don't worry about it. It went okay last time. Just take a deep breath, and talk about it and until eventually those kind of questions come back up again. Another way to think about this when we're addressing anxiety, in order to address anxiety effectively, we have to be able to do it in such a way that doesn't allow for those two functions of anxiety. So we need to prevent escape and we need to prevent avoidance as best we can. One of the ways that we can do this in this scenario is called a strategy that we call acknowledge and defer. There's two steps. You acknowledge the anxiety and then defer discussion about it until later. So, and you can acknowledge the anxiety with empathy, right? I understand that you're feeling really worried about the upcoming visit, and we'll talk about it later, I promise. And then one thing that you can do is you do talk about it later, but you do it in a very truncated period of time. I would say 10 minutes is probably plenty of time to provide the opportunity to talk about something that your kids are worried about. And what you would do is you want to do it like at a time where it's kind of free of other distractions, where you can kind of do it one-on-one. I don't recommend initiating this conversation at bedtime. Right before bed is not really the best time to talk about all the things that you're stressed and worried about. So you want to do it, removed from bedtime. But you can just say, all right, hey, we have some time right now. Is there anything that you want to talk about that's worrying you or that was worrying you earlier? And if there is something to talk about, you can talk about it then in a way that you typically would. You don't need to overthink it. You can kind of just speak normally about it. What we've found, though, with this strategy is that oftentimes, by the time you get to this deferred time, kids no really longer have a desire to speak about anything. And that's primarily because in the presence of acute anxiety or when they were stressed, that's prompting them to ask these questions and getting the kind of reassurance from caregivers, right? Well, when they're not necessarily getting that reassurance, right, the discussion, they're just getting an acknowledgement of the anxiety and then a deferred discussion later. It allows kids to sit with anxiety for a period of time that shows them that through no other intervention alone, the anxiety can decrease by itself over time. And this is a much more in the long-term effective way to address anticipatory anxiety because it shows kids through their own experience that anxiety comes down on its own. Despite my feelings of worry, everything ended up fine. And people, I'm sure, have told you, especially when you're anxious, if you shared your own anxiety with someone, you've heard things like, oh, well, try not to worry about it. I'm sure it's going to work out. Often, try not to worry. It doesn't help very much, right? It's like, well, if I could choose not to worry about it, I wouldn't, but I am worried about it. And so really it's through this kind of process that we can really encourage kids to just be able and give them the skills and the confidence to sit with their anxiety and have it dissipate over time. And then also we can encourage them to re-engage with expected behavior, right? If they come to us with a question, I understand that you're really worried about that right now, but why don't you go back and start playing again? Or why don't you go get in the car? It's time to leave, like those kinds of things. I know I have to move really, really quickly with some of these things, and so there's going to be more detail to some of these than others. But in terms of delayed tactics, the best way to reinforce behaviors that we want to see is through reward systems. And generally, these look different depending on the kid, but there's a best and kind of most evidence-based way to approach these. And with the reward specifically, highlighting attention or privilege-based rewards more than tangible rewards. And tangible rewards tend to lose their luster pretty frequently or pretty quickly, whereas privileges like screen time, an extended bedtime, or attention-based rewards like a one-on-one game or a one-on-one outing with a parent that's contingent on expected behavior have a lot more staying power when we implement strategies with that kind of a reinforcement system. Also, in terms of anticipatory anxiety, sometimes, always parents, I've found, have their kids' best interest at heart, right? And sometimes we want to protect them. Always we want to protect them. And so in terms of discussing illness, how do we talk to kids about illness? Really, the recommended approach is just to be able to be sure that you're providing age-appropriate information to children regarding their illness. What's age-appropriate information? Well, it's hard to say. It depends on the kid and their level of development. But one kind of gauge that you can use to judge appropriateness of that conversation is what are the questions that they're asking? A teenager is going to ask a lot more complicated and detailed questions than maybe a kid that was diagnosed at age 5 or age 6. And so when the question is asked, the idea is that you just answer the question that was asked, and as best you can, avoid kind of gray areas or unknowns as best you can. So in short, answer questions honestly, and most importantly, don't hide facts, right? Kids know what's going on. Kids know when they have an illness. They know that they need to go to the doctor for something. And we know that anxiety is much more reduced when they're in on all the information as well. If you're ever put into a position where you don't really know the answer to a question, that's okay. You don't have to know the answers to everything. Saying, I don't know the answer to that right now is a perfectly acceptable response. Okay. With more procedural related anxieties, so this has to do with like needle sticks, the methotrexate injections, infusions, I just hope that parents generally feel empowered to advocate for things like a poke plan. Many hospitals will be able to help create a poke plan for you and your child to help speed up any infusion or injections that might be needed. If hospitals are not able to do that, you can create one on your own. Pretty much, you just outline the steps that make the process as expedient and as quick as possible. Does your kid like a stuffed animal to kind of hug when they go through this process? Do they want an iPad as a distraction? Do they want nothing at all? Do they want to do some breathing with you? Do they just want it to go as fast as possible and have the nurse come in and do it really, really quickly? It depends on the kid, and being able to have something that's kind of written up that you can provide and show to people that are going to be doing these things kind of can help a lot of times this process goes as smoothly as we can. I also encourage a lot of parents to advocate for a child life specialist. These are people that can come in and provide distraction and engagement and support to your child when they're going through any kind of a procedure. And I hope parents feel that they can ask for that whenever they feel like it would be helpful. Also, it's okay to ask for specific providers. If specific providers are available that have a good relationship with your kid, you can ask for them, and I hope that you do that. It's also okay to ask for a different provider if you don't think things are going well. If they miss a vein on a first poke and your child's really uncomfortable, you can ask for someone and advocate for someone else to do it. When to ask for help for things related to anxiety. I hope caregivers should ask for help with anxiety if they believe that just symptoms generally are really negatively impacting a child's ability to engage, or if their ability to engage is with significant difficulty. For example, if we're seeing that kids are refusing to attend school or extracurricular activities, not wanting to leave the house, or having significant difficulty with sleep or separating from parents, that would maybe be a time where an assessment or a referral to a mental health provider would be beneficial. Caregivers should also help with needle phobia if they don't believe that they're able to perform injections safely or without significant distress. Usually, treatment involving needle phobia involves relaxation training first, followed by kind of tiered exposure plans over time that parents would also be involved in. It's fairly straightforward and very effective, but best done with a provider that can help guide you through that process. In terms of low mood or depression in the clinic that I'm in, 32% at first visit appointments with me of parents endorsed mild or moderate depression at first visit. Pretty significantly less children endorsed mild or moderate depression at first visit. That could be for a number of reasons that I can't really elucidate right now. But again, this is just data that was collected at first visit to essentially indicate that anxiety and depression are present in this group of kids, and it's something that I think is really, really important that we work on. So for depressive symptoms, psychological symptoms of depression, persistent sadness, of course, loss of pleasure in doing things, feeling tired, difficulty staying asleep. As opposed to anxiety, oftentimes the difficulty with sleep is falling asleep. With mood, it's often staying asleep, not always, but often. Difficulty concentrating or difficulties with executive functioning processes. This can impact things at school, as can anxiety. Physical symptoms of depression include headaches, stomach aches, decline in adequate hygiene or activities of daily living, not wanting to shower, not getting dressed, not caring for yourself, that kind of stuff. Less common in younger children than in adolescents. In child depression and anxiety, it can often, one thing to keep in mind is this can often manifest as frustration or anger. Like anxiety, it can be hard sometimes to differentiate depression from chronic illness. Fatigue is associated with depression, but also with some of the medications that kids have to take for JDM, or even side effects of medications like initiating steroids versus weaning off of steroids. We can see similar symptoms. But again, as we get more experience with our kids and in clinic, we're able to kind of determine, essentially what's maybe more depressive and what's maybe more related to physiology. There's a lot of topics to discuss with mood, but the primary one I would say is just this withdrawal cycle. I would say that we want to keep our eye on avoiding a withdrawal cycle, essentially. What this means is essentially anyone who's experienced a low mood at any point might be quite familiar with. You kind of just feel tired, you feel unmotivated, reluctant to engage. Because you kind of feel tired and just down, you don't want to engage socially, participate in other activities, you don't want to be active or kind of get out and do anything. The problem with that is that we are inherently social and physically active creatures. We need that activity. We need this interaction. And without it, we don't get the kind of positive reinforcement that we do when we are active and we are able to kind of interact socially. And when we're not able to do those things, our mood tends to sink lower. And this is what we call that. And then we're less likely able to kind of get out and do those things again. And so that's what we call a withdrawal cycle that we want to keep an eye out for. Now, I want to also keep in mind that this is distinctly different from needing to withdraw due to medical reasons, right? I mean, sometimes our kids aren't able to engage in physical activities the way that they once were just because of their diagnosis, right? Maybe they're in an active stage of disease. And so that's distinctly different. It can certainly result in lower mood and depression, but the primary treatment target and treatment goal in that case would be following medical recommendations, making sure you're taking your medication appropriately. I mean, you should always be doing that, but mood is kind of secondary to the presence of symptoms. Whereas if depression or low mood is primary, we maybe need to consider some other options or other kinds of forms of treatment and engagement. And what that looks like is essentially pleasurable activity scheduling. Now, again, this is very patient specific. It seems straightforward, but in the mix of especially maybe a new diagnosis or a chronic illness diagnosis in which we're not only navigating school and work and medical appointments, we also need to navigate making time for pleasurable activities. And sometimes these need to be adjusted based on the physical capabilities of our kids, right? Are they in active disease or is it in remission? Those kinds of things. Generally, if possible, children should engage in a pleasurable activity that is either social or physical in nature for 30 minutes every day. Plan these activities while being mindful of potential limitations due to active disease. And to the degree that kids are able to, I do recommend that they maintain participation in extracurricular activities, even if their role might look different. So still kind of having contact with those kind of support systems and semi-structured activities, I think is really important. Another thing to mention is setting limits is still okay in the context of a chronic illness. It's okay to set limits of behavior, screen time, reinforce house rules despite the presence of chronic illness, or symptoms. I think that parents should feel empowered to still kind of have those expectations of behavior. When to ask for help for issues related to mood. If you're concerned that your child has become withdrawn and is in that kind of withdrawal cycle, cries frequently and is not sure why, or is sure why, but isn't able to kind of move past it, expresses hopelessness, those might be issues or times when you might want to reach out for additional support. If they do talk about hurting themselves or stating things like, I wish I wasn't around anymore, I wish I could go to sleep and not wake up, or kind of some of those general statements about suicide could be concerning or indicative of maybe getting some additional support. We kind of categorize phrases like that as passive suicidal ideation, which is, believe it or not, quite common, particularly when people are stressed or going through something that's really difficult. We become more concerned when we have what's called active ideation, which then includes things like a plan or intent to commit suicide, which we certainly would want to reach out for more emergent support at that time. The other thing that I do stress with regarding mood is that it is okay to ask very directly about thoughts of suicide in kids. Sometimes there's a misconceived notion that bringing up thoughts of suicide or the topic in general can kind of plant an idea in kids' heads that it might be an option. What we know from research is that it isn't the case. And what it actually does is it opens lines of communication to make sure that everything is on the table in terms of what we want to talk about. And so if you feel like you should be asking about mood or thoughts of suicide, I would encourage you to feel like you can do that. An example is just to be very direct and ask with empathy. The example here is, have you been thinking about suicide? Not, you aren't thinking about suicide, are you? The idea or why we might ask a question about that comes from a parent's place of concern, right? Like we don't want our kids to be thinking about these things, but kids also want to please. You know, they want to make their parents happy. They don't want their parents to worry, and so we want to phrase our questions in such a way that we get more often than not a truthful response. And generally, if you have concerns about safety or your ability to keep a child safe, of course, calling 911 or taking a child to a pediatric emergency department is of course always appropriate if you're significantly concerned about safety. In short, and to kind of wrap up here, I know this is really quick. The good news is that children are extremely resilient. Children thrive when their lives are consistent and predictable. A unique challenge of kids that are newly diagnosed or diagnosed in general with a chronic illness. But in general, the more quickly that we can establish new routines in which our child knows what comes next, things are predictable and expected, the more likely in general we are to have positive mental health outcomes. So thank you very much for listening to that. I hope I didn't have to go too fast there, but I really appreciate you guys letting me talk today.
Thanks, Luke. Thanks. Okay, in the interest of time, we're going to move on to Rhonda. Rhonda Thorington is a licensed professional counselor and parent coach, and she is the founder of Resilient Parent Consulting, and she lives in Connecticut and is also the parent of a child with a chronic illness or living with a chronic illness but doing well. And we'll just let Rhonda take it away from there.
Great. Thank you so much, Suzanne. And thank you, Luke. You have, there's not too much overlap, but you allowed me to skip over some things in the interest of time. So let me just share my screen here.
Shannon, can you highlight Rhonda? Perfect. Well, but not on the side. Rhonda needs to be on the side.
Let me see. I'm just making sure that I have.
Yeah, I'm trying to do it, Suzanne.
Okay.
I just gotta find Rhonda. There we go.
And I have to find my presentation. So
It looks
It's
good.
up there. We see it.
Yeah,
it's
we
up
see
there.
it.
Okay. I just need to see my notes. Okay. There we go. Let's see. Okay. Bear with me, guys. I lost. Here we go. There we go. So let me move myself out of the way here. So when we are talking about parenting children with a rare disease diagnosis, so I'm going to take a bit of a different shift. Luke, you teed things up so nicely. I'm going to talk a little more about some of the day-to-day nitty-gritty practical things that we all go through as parents of a child with a chronic illness and children that experience chronic pain. So what I first want to establish is that whatever you are feeling as a parent, it's normal. Okay. Different stages of the diagnostic journey are going to produce different feelings. With an initial diagnosis, you may feel shock, disbelief, confusion. You're going to feel grief and loss, loss over the life that you thought you were going to have. Maybe you will mourn your professional life. Just all of those things can produce some pretty intense feelings in yourself. You might have anxiety as a parent, anxiety about the future, anxiety about treatment options, the long-term impact of medications and your child's diagnosis. You may experience feelings of isolation, feelings of overwhelm, frustration, exhaustion, right? We all experience that. But here's the kicker. All of those things that you experience as a parent, your child feels those things too. So they may feel these things for different reasons and at different times, but those feelings are there. So the important thing is being in touch with what you're feeling, because that can help in understanding what your child may be feeling, giving yourself a window into their experience. So capitalize on that. So there are some things that impact mood that we may or may not even be aware of. And Luke touched upon these things as well. But, one may be the impact, the effects of chronic pain in general, right? How many of us have had an injury that's gone on for a significant period of time, and it can make us really cranky, right? We're not always joy and sunshine to be around when we're not feeling well. So the same can be true for our kiddos as well. Chronic pain impacts a person physically, but also psychologically. I remember early on, I was treating a kiddo who was like 3.5 and had gotten kicked out of 2 preschools, about to get kicked out of his 3rd. And his family came to me and was like, help me, help me. And I was like, I don't know what I can do. But what ended up happening is I referred them back to their primary doctor, and this kiddo had chronic ear infection. So he was in pain all the time. They fixed the ear infections, and his behavior improved exponentially. So he went from potentially getting kicked out of his 3rd preschool due to behavior to being like the star of his preschool class. So that's just a little snippet of how physical pain can impact a person's mood and behavior. Medication is also can also impact mood, and Luke spoke about that as well. You know, we talk about the impacts of high dose steroids, how they can impact mood. There are other medications as well that could potentially impact mood as well. So it's important to kind of be mindful of that, to kind of keep that in the back of your mind. You know, sometimes anti-epileptics medications can impact mood. So just being aware of that in the context of what our kiddos are experiencing is important. The other thing that can impact mood that we're not always aware of is the disruption in our routines, right? Kids thrive on structure. You know, as much as they may balk against it, they thrive when there is structure. Structure allows children to feel safe. So when our structure, our routines are disrupted, it can be incredibly destabilizing for kiddos. You know, if Johnny is expecting pizza, because y'all have pizza every Thursday night and it's Thursday and y'all are at the children's hospital and he's not getting his pizza, it may be upsetting. So just kind of keeping that in mind, that these are some things that can also impact our child's mood. So all of these things, right? All of the things that Luke talked about, all of the things that I'm talking about can lead to some pretty big feelings in our little ones. So what can those feelings look like? Sometimes it looks like, you know, pretty ugly behaviors. Sometimes it looks like some scary statements, right? Such as, I hate my life, or I wish I was never born. Why did God make me like this? Or I wish I was dead. Now, these were all statements that throughout our diagnostic journey, these were all statements that my daughter made at times. And I have to say, as you know, I'm a clinician, I'm supposed to, this is my wheelhouse, right? This is my jam. I'm supposed to help kiddos that have these very big feelings, to kind of shrink them down and to discover alternate ways of coping. But I'm a parent first, I'm a mom first. And it was incredibly scary to hear my daughter, my girl, say these things. So what do you do? What do you do as a parent? How do you respond as a parent when your kiddos are, you know, in this space, in this very difficult space? Well, one of the things you want to do as a parent is you want to define what it is they're feeling, right? Because many times kiddos don't know what's going on with themselves emotionally, especially our littlest ones, right? They may not know what it feels like in their body to be angry. They may not know what it feels like in their body to be anxious or scared or worried. So what our job is as parents, one of our many jobs, is to help them figure it out. So give them language to what they're feeling. There are lots of resources out there for parents, to like books that you can read with your littles to help them define like the particular feelings that they're having. But some things that you can say to your kiddo is, it looks like you're having some pretty big feelings right now, you know, and you can generate a discussion around that. You know, another thing you can say is, this feels scary, doesn't it? If you're looking at your child and it seems like, wow, they look really sad right now, or oh wow, they look really mad right now, or you know, Johnny looks really worried right now, it's okay to say it. Johnny, you look like you're really worried. Let's talk about that. Johnny, you look so sad. Are you feeling sad right now? Because a lot of times kiddos, like I said, they don't know what they're feeling. And when you can help define it, then they can be like, ah, that's it. That's exactly what I'm feeling. And then you're helping them to build their emotional vocabulary. Another way that you can respond as a parent, and this is what, I was able to do when my daughter was making those very scary statements, is respond with curiosity, right? Try to get to the feeling that's behind the statement and the behavior. Focus on the feeling. So instead of focusing on the fact that, so-and-so's kind of, tearing up papers and destroying their room, it's about, wow, you look like you're really mad right now. Let's talk about that. And caveat, anytime a child, though, is doing things that are unsafe, you always want to focus on safety first. So I'm speaking more about, when children make statements or are engaging in behaviors that are undesirable, but not necessarily unsafe. So there's that caveat. So here's an example. When you told me that you didn't want to be here anymore, were you feeling like you want to die? And that's what Luke was talking about. It's okay to address the elephant in the room, right? If you think your child's making suicidal statements, you need to talk about that. Sometimes with our littlest ones, they may make statements like that and not really understand what it is they mean. In this day and age of video games and virtual reality and all of that, sometimes kids will think, oh, if I die, I'll come back. So kind of, getting to the bottom of that. And sometimes kiddos will make those statements because it's like, okay, I am so mad, I'm so upset, I'm so scared, and I need for the grownups to pay attention to me. And I know if I say this, then they will pay attention to me. So really approaching it with curiosity. Your actions are showing me that you are feeling blank. Is that correct? Am I understanding correctly that this is what you're feeling? And then the part B to that would be, okay, let's see how you can use your words to let me know how you're feeling instead of your actions, because you get a lot further by using your words than your actions. Another way to respond as a parent would be to circle back to what you know for sure. As a parent, just like Luke said, you don't have to have all the answers, right? Okay to say that you don't know, but you always want to circle back to what you do know for sure. Johnny, I don't know for sure if this new medication is going to work to help your pain. The doctors are pretty confident that it will, and we're hoping that it will. But, honestly, that's why it's called a medication trial. We're going to try it. But even if it doesn't work, we're going to continue looking for medications until we do find one that works. Kind of settle back onto what you know for sure. This is the other thing we know for sure. We are a family, and that will never change. No matter what you're going through, I will be with you no matter what. And we're going to figure out a way to manage this. So circle back to what you know. Another way to respond as a parent is to focus on what you have control over. As a parent, we may not be able to control what is happening, but we can control how we respond to it. And that's a way to empower our kiddos, right? One of the things that I always used to say to my daughter when she was younger is that, sadness is a neighborhood that you can walk through, but you can't build a house there. So I don't have any control over what is happening to you, but you have control how you respond to it. So when you find that you are in need of more support, right? What does that look like? You might need additional support if you're having difficulty functioning. If you or your child, if you're finding that you are having extreme emotional reactions to things. Like when I work with my littles, I often use like a feeling thermometer, right? And like, let's say we're targeting anger. And if your feeling thermometer, if you're responding to something and you're at a 10, but it really should be a 3, and that's happening more often than not, then that might be a sign that you need some additional supports to help with that. Another sign of you being in need of additional support is when there's a communication breakdown between family members. If all of a sudden folks aren't talking to each other, or every time they are talking to one another, it ends in anger or discord or arguments, then that's a sign that you might need some additional supports. You know, if you or your child are withdrawing from life, you know, you're not engaging the way that you typically would. Anytime there are feelings of helplessness or hopelessness, when you notice a change in your child's behavior at home or school, you know, if a child is withdrawing, if a child is having aggressive behaviors, you know, anytime there's just a marked change in presentation, that might be a sign that you need some additional supports because there's something going on. And lastly, you may need some additional supports if you notice that you or your child are beginning to use some unhealthy ways to manage stress. So, you know, whether, you know, you are self-medicating with drugs or alcohol or food or sex or excessive spending, you know, if you're engaging in all of those things as a way to cope, then that might be, that's definitely a sign that you need some additional support. And that additional support can take many forms, right? You know, what we're talking about today is specifically when to engage a therapist, but, you know, support can also look like, you know, joining a support group with people that have similar experiences and are experiencing similar challenges as you. You know, support can look like engaging, you know, in the services of a parent coach or doing some consultation, you know, with someone who can kind of help give you some specific strategies to, you know, kind of help your family navigate things. So, and also, like I said, today is about figuring out, like, how do I find a therapist, engaging a therapist in support services. So I developed this graphic. It's a little busy, but I think it kind of encompasses some of what, you know, I talk with folks about when they're looking for a therapist. This is kind of the decision tree that I follow. So one of the first things when you are trying to find a therapist for your child or yourself in dealing with a rare disease is you want to find out, does this person have experience treating rare disease? Okay. There's not a ton of clinicians that do. There are some and more every day, which is awesome. I have to say, when my daughter was first diagnosed 12 years ago, there was like nobody. But now there are more clinicians. So that's a good thing. But the first question is, does the clinician have experience treating rare disease? If the answer is yes, then it might be a good fit. If the answer is no, then the next, you know, step you want to go to, the next question you want to ask, does this clinician have experience treating chronic illness? If the answer is yes, then that person might be a good fit. If the answer is no, then the next question would be, okay, does this clinician have experience treating chronic pain? You know, if the answer is yes, again, it might be a good fit. Bonus points if the clinician also has trauma training, or at the very least treats their clients through a trauma-informed lens, meaning that they have an awareness of the impact that trauma can have on people physically and emotionally. So every therapist who's trained these days should have that, but we cannot take that for granted. So when we're looking at, so we found someone who we think could be a good fit, right? So the next step would be reaching out to that person and asking for a consultation. Now, most therapists offer consultations by phone, video, or in person. And a typical consultation will be anywhere from 15 to 20 minutes. Sometimes they're a little longer. My consultations tend to be a little longer, but you want to make sure that you take advantage of that. You know, if you are looking for a clinician for your family or for your kiddo, you know, I always encourage people, though you can do it by phone or video, I always encourage people, go in person, especially if your kiddo is going to be seen in person. You want to check out the office, check out where your child is going to be. If the therapist says, yes, I do tons of work with kids, and you only see a lonely teddy bear in the corner and no other toys, that might be a sign that this person may not be the right fit for our child and our family. So, and what that does when you go and meet the person in their office, then you can go back and tell your kiddo, guess what? I found somebody who's a feeling helper. She has cool toys in her office. She seems really nice. I think you should meet her. So it kind of builds credibility off the bat. So there are some important questions that you want to ask, but in the interest of time, I'm not going to go through every one. But basically, these questions get to the heart of, what is your experience and expertise? And what can I expect from this whole therapy thing? How long am I going to be in therapy? How will I know that this is working? And what if it doesn't work? How do we continue to check in and continue to evaluate this whole process? So now, where on earth do you find potential therapists, right? So these are just some resources. One would be Psychology Today. Psychology Today is a publication, but it's also it's a website as well. And what I like about Psychology Today is you can search for clinicians and put in particular filters. And I was playing around with this earlier, and they have a filter for different diagnoses. They have filters for child therapists, chronic illness, chronic pain. And once you put in those filters, up will pop, different therapists, and you can read their bios. And the other thing that I like about Psychology Today is it will say on a therapist profile whether or not they are taking new patients at this time. Because anybody who's been looking for a clinician, in the past 4 years knows that everybody's practice is crazy full, and it's really hard to find someone that has availability. So when you go on Psychology Today, you can at least see, oh, wow, okay, this person does have availability, so let me reach out. Another organization is Give an Hour. Give an Hour is an organization. They have volunteer clinicians who work with families. They volunteer their time to work with families and individuals that are experiencing different issues. They work with veterans, they work with mass violence, and in the last few years, they've also gotten into the rare disease space as well. So, I recommend Give an Hour, and they're an organization that really puts their money where their mouth is, because they're investing time and money into bringing people in to train their clinicians on how to work with rare disease families. So I give an Hour 2 thumbs up for that. Global Genes is another organization that works with rare disease families and individuals. And Global Genes is a great connector. So they have a rare concierge program where patients, you contact them, you let them know what your need is, and they will connect you to different mental health providers that have experience in rare disease. So you can also find someone by connecting with different rare disease organizations, because particular organizations will have contacts for different therapists, and also asking around as well. That is how you can find someone, because what I will say is that, when you have a reputation of, you're someone good and you work with rare disease, your name gets around. So, so if you ask around, you'll be able to get some good resources as well. So, and lastly, when we look at building support within the family, the importance of that, when you get a diagnosis of a rare or chronic disease, it is incredibly challenging, incredibly destabilizing, and life as you know it feels like it's over. Okay. So, and the normal that you had before is kind of done, but there is a new normal that exists, and that you had, the beauty is that you can help to create that for your family. And one of the ways that you can do that is by asking for what you need, right? I mean, it sounds simple, but how many of us really do that? You know, I know that, you know, as a mom with a kid with a rare disease, I'm not real good at asking for help. But what I found along the way is if I can be real specific, then it can help lessen the stress, and I can get my needs met. So that may look like, girl, can you come over on Thursday at 2:45 and sit with Johnny so I can take a shower? Or I ran out of coffee and haven't gone grocery shopping. Can you go to Starbucks and get me something and drop it off at my house? So being very, very specific, because the other thing that I've learned is that, you know, our friends, our family, our extended family, they want to help, but they don't always know how. So if we can be specific, people will just fall over themselves to provide assistance. The next thing would be to make room for siblings, right? So, you know, we have, in our family, we have three. My daughter with the rare disease, she's smack in the middle. She's got a brother who's 21 months older than her, and her younger sister is about almost 3 years younger than she is. So what we found to be important is that each of our children had to have some one-on-one time. So much time, attention, and focus goes to the child with the chronic condition, as it should, because they have a lot of needs. But you want to make sure you are giving time and attention to the siblings as well. So what does that look like? That could be, you know, Johnny, come with me. I'm going to the grocery store and I want to spend some one-on-one time with you. So you're walking through the grocery store, getting groceries, and just chatting about life. You know, it doesn't have to be, you know, a trip to Disney World, right? It could be, it doesn't have to be. It can be a quick 5 or 10 minutes, you know, one-on-one, so that they don't feel lost in the shuffle. And lastly, you know, when we look at building support within the family, we want to be careful to not neglect our other relationships. So that means if you have a partner, making time to spend with that partner. You know, as Suzanne often says, you can't, you have to put on your oxygen mask before you put on the masks for your loved ones, right? We have to fill our cups. If we don't fill our cups, then we can't take care of others. So, and your partner is the one that knows intimately what it is like to be in this rare disease life better than anyone else, because they're in it with you. So capitalize on that. So that is my presentation. I will say that, you know, based on some of the questions that I read, this is hard. This is incredibly difficult stuff. It is incredibly challenging, but what I will say is that there is joy to be found. There is joy to be found. So just breathe, give yourself a minute, and move forward. Thank you.